first conversation. I'm looking at Bob right here, and our commissioner to come up and lead us in a conversation.
Great. Is this on? Yes. Okay, good. Good morning, everyone. It's great to be here with you all and really thankful to have Commissioner Francis Mills with us as well, and happy to have this semi-informal chance to have a little fireside chat without a fire here with us this morning. So it'll be great to be able to learn about Commissioner Mills, the work she's leading, and really what's happening in Cleveland more broadly that I know each of you are a part of. Just wanted to give kind of a brief overview. I actually had the honor of speaking with Commissioner Mills back right before I started this role 9 months ago as the president and CEO of Better Health Partnership. I'm Robert Eick, by the way. And it's really been interesting to see over the last year how much alignment we've had with what Cleveland Department of Public Health has been focusing on across infant mortality and other areas around lead, et cetera. So really a pleasure to be here and to learn from Commissioner Mills and to have her share kind of what her vision has been, how's that evolving kind of in the near future, and especially given what's happening around us federally in the state, how those core principles are holding true and what that looks like in the near and upcoming future. So really grateful to be here with Commissioner Mills and be able to think about what does multi-sector collaboration look like as we have so many sectors here. I know at BHP, we're fortunate to bring together folks with lived experience, folks from the community, healthcare providers, other community-based organizations, public health, to really have collective action around specific initiatives. So with that, let's jump in. Commissioner Mills, would you like to introduce yourself to start off, and I can start asking some questions maybe?
Sure. For those of you who don't know me, and I'm looking out in the audience and I see a lot of friends and colleagues who are out there and have been out there for some of you for many, many decades, and some of you for the last 5 or 10 years. I work for the Cleveland Department of Public Health, and I serve them as the health commissioner. Do you want to know what that means?
I would love to know that.
Okay.
That'd be wonderful.
What that means on a day-to-day basis is that the Cleveland Department of Health has 5 divisions. We have a division of health, we have a division of environment, we have a division of health equity and social justice, and we have a division of administration and a division of air quality. What the division of health is responsible for is providing oversight for several different key programs and initiatives. I help coordinate the work of our epidemiology department, emergency preparedness, our nursing and clinical services, which are offered through 2 health centers, our food justice work, and a portion of the health outreach work that is happening in the city of Cleveland. And so when we talk about breaking down silos within a health department, we have to have cross-sector collaboration within our building before we even go out in the community to address some of the issues that so constantly and pervasively affect the residents of the city of Cleveland and Cuyahoga County.
Great. Thank you, Commissioner Mills. That's a helpful overview. So thinking kind of about that broad scope of work that you and your team are overseeing and leading, how are you thinking about embedding efforts to address health-related social needs within kind of that broad scope of programs? And can you share how these themes kind of come up across those different programs, maybe in different flavors?
Well, I mean, we have to look at our community largely. What do we look at when we see the members of the city of Cleveland? We live in a city that has a whole lot of assets, a whole lot of people assets, but at the same time, we're challenged by some complex problems predicated by poverty, predicated by the need to better and more effectively collaborate. And so what it looks like is, what is public health? Public health is designed to prevent disease and prevent death and to improve care for people. And so when you look at that, we have to say, we know in public health we're about equity. Equity is at the center of all that we do. And so we make it our business to, what can we do not only to help all people, but to help people who need the help the most. And that's what's been our focus. That has to be our focus today and in the future.
Great. That's wonderful. Thank you. And I, looking out here, I see a lot of partners that I'm sure all of us work with, and it's like a bit of a family reunion maybe in some ways. So it's nice to see folks, but obviously seeing folks from First Year Cleveland and Carmela Rose and Benjamin Rose and the food bank and area agencies on aging and UH, et cetera. One question I would have is, what role for you all does data play in what you've highlighted so far, especially considering the importance of that data to kind of feed risk stratification, community engagement, and knowing that sometimes those systems don't want to talk for sometimes regulatory reasons and sometimes technical issues, right? So what's your approach to that, and how can we maybe think about that in a way that helps us be better connected across these multi-sector partnerships?
Well, in the middle of complexity and a lot of moving parts, data for us at the health department, everything starts with data. We need to learn and continue to understand the scope of the problem, the pervasiveness of the problem, who's experiencing the problem, what are the barriers related to the problem. And so a lot of time is spent. I remember when I first started at the health department, I started out as a grants manager that morphed into a community engagement person around infant mortality work. And it was data that we took to community members and stakeholders. And the question was that I had for community, did you know that Black babies are dying? And so the answer to that for many people was absolutely not. I did not know that Black babies are dying. Why is that? And so it starts with data as an awareness tool, as an understanding tool, and as a planning tool to develop strategies to help. And so when we develop data briefs within the health department, or we partner with county health department and nonprofit organizations, we're always looking at key different aspects of the data, like our partnerships with you, to say, what do we know in the public sector, but what do you know about what's happening on the hospital side and what's happening on the nonprofit side. So data is everything. It's the beginning and the end of our planning processes.
Sure. That's helpful. Yeah. And I think for me, maybe dating back a decade, when there was this initial push to screen for unmet social need, it seemed like an academic exercise at first, where we were screening at scale, but there were no tools in place to actually address those needs. And then those who were screening for those were actually demoralized because they didn't have any resources to refer folks to in a cohesive closed loop way. So what I'm thinking now is, with that data piece either in place or getting in place, how are you all thinking about getting community voice involved as co-creators of solutions and so forth, once there's kind of baseline data and an acknowledgement of what the issues might be within the community?
Well, community voice is supremely important. And I think we're at a time in the Cleveland-Cuyahoga County community in which we're balancing, there's competency and skill and experience from a professional standpoint, from a clinical standpoint, but lived experience brings us into clear understanding of what's happening. And I'm looking straight out and I see Carmela Rose, and I think Karen Cook back there. You can't have, you have the data piece, you have the lived experience piece, but then you have to have boots on the ground who actually know how to reach people in the community to offer the assistance that is necessary. Everything is predicated on relationship. If there is no relationship, there's no level of credibility or trust to even enter in to begin to talk about solutions.
Thank you. Yeah, and so for me, one thing I'm thinking is, I felt this in my career and continually today, even working with a community health worker led model, that often it feels like there's definitely an ivory tower that I'm sitting in at various levels, and there's sometimes a lack of connection to what's happening on the ground, in a way that I realize that sometimes when we think about co-design or really community driven work, really wanting to avoid shiny wrapper things, that are checking a box, but actually don't impact how we're designing a model for us around lead or infant mortality or behavioral transitions of care. So do you have any thoughts or things you would share on kind of how you've seen the trajectory of, oh, we're checking a box around community involvement to actually having community active involvement around co-design, and has there been a trend or a progress you've seen over your career in that space?
Sure, I say this all the time. There's a continuum of community engagement. And typically what happens in communities is we go to communities and we say, hey, this is what we think is happening, and this is what we're going to do. What do you think? Versus taking the expertise of the lived experience, because sometimes the solution that we come up with might not be the solution that community members want at all. To feel engaged, to feel like their community is safe, to feel like they're contributing to the solution. And so it is imperative that we co-create together. And that involves a lot of humility. That involves sometimes swallowing your best thinking in favor of someone else's idea or someone else's opinion. And I think we learned that very clearly during COVID. There were times where larger organizations had to stand down and listen to community members who said, well, we don't want you to do these things that you typically do or the things that you think you're good at. We want you to do A and B and let us handle the rest. We want to be the front people. You just give us the vaccine. We don't want, this is how we want this to roll out in a way that we feel is going to be best for the community. And so you have to have the ability to leave your ego at the door and to move forward in the role that it would be most beneficial for you.
Thank you. Yeah. So one thing I'm hearing you say is kind of the importance of humility, as you mentioned, and then a role for like a real assessment of assets and power. And I think traditionally that's been really one-sided in terms of who's held power in these spaces. And now hopefully there's a distribution of that in a way that's recognizing that the community doesn't just have needs, but they have assets. And how do we leverage that? And so that's really helpful insight from you. So I appreciate it. And so if we're thinking about kind of power and assets and communities and helping to be able to help lift that up in partnership to really surface those voices, thinking of that in light of the workforce and maybe around CHWs or community health workers, and knowing that for us in the work we do at BHP, those are pivotal experts in helping move health forward. And they are folks who have lived experience and assets that no one else in the system really has. And so how can we maybe think about the role of a CHW or other lay health workers in terms of being key parts of moving some of these public health focused efforts forward?
Community health workers are absolutely essential. The Cleveland Department of Public Health since 1991 has had a program called Moms First, which is a case management home visitation program that uses community health workers. So we have a little bit of experience in how helpful that is in getting care to women and getting families where they need to be in the effort to reduce infant mortality and eliminate disparities. But community health workers are everything. And I think that Cleveland has a huge advocacy, has been engaged in a huge advocacy effort around the importance of community health workers, paying community health workers, dispatching community health workers, whether it's infant mortality, whether it's behavioral health, whether it's addressing social determinant of health needs. We've got great resources here at Tri-C, great resources at Cleveland State. The community worker health model has taken on, that has had a lot of push from Carmela Rose, from so many organizations, and we need those boots on the ground. If you want to get something done, ask a kid, ask a community health worker, you'll get an answer that is useful.
That's awesome. Thank you. Yeah. And so I think maybe just stepping back a bit, my experience being from Northeast Ohio and now recently coming back after 20 years away, is that there's a long history of public-private collaboration here, and you can feel that, and it's very vibrant. And I think folks who even might be competitors in other situations actually are really close friends and partners, and there's a lot of collegiality and shared mission and things. We see that across hospitals, nonprofits, public health, community groups coming together to tackle common objectives. I think at the same time, we know that Cleveland still remains one of the most deeply segregated cities in the US. The persistent disparities slap you in the face when you see the data. And it looks like around life expectancy or infant mortality or chronic disease. And so given those pieces, how are you approaching kind of some of the biggest structural wins that you've seen in light of kind of the state of things? And what are the biggest challenges kind of on the flip side that you see are yet to overcome to actually address those issues?
Well, I think there has been probably in the last 10 years, a willingness to even raise the issue of disparities as it relates to the data that you said across the board, and to call out racism where it is in our community. That was a big deal. And we really began to focus in on that in earnest around 2014, 2015, when our community was really being devastated by infant mortality among African-American families. And for the health department, we had to pivot. We were given a directive to every single initiative that you're working on within the health division, you need to be coming up with collaborative solutions around infant mortality. And so that work began to morph, and we began to be able to call out racism to the point that the work that was happening in the maternal child health space sort of morphed, and with energy, with some work that was being done where different nonprofits said, hey, if racism is a thing, then we need to talk to our policymakers about declaring racism as a public health crisis. And so we were able to accomplish that as a community in 2020. And then the city passed legislation, the county passed legislation, and then groups began to really energize around this issue. We have a Racism as a Public Health Crisis Coalition. We have a group called Casey that's working on the county level, Policy Bridge, the NAACP, Urban League, First Year Cleveland, lots of groups coming together to address inequities in multiple sectors. And so for us, that declaration meant, how do we operationalize this within the health department? And so a lot of work was done with some founding organizations, United Way, First Year Cleveland, NAACP, Urban League, to develop a framework for equity that made some very key recommendations to then Mayor Frank Jackson. And he looked at the framework as it was articulated, and he made some tweaks to it. And he said, I'd like to see this work live on. One of the recommendations that was made is that we need a cabinet level person who are addressing equity issues. And he said, I'd like to see that work be housed in the health department. And so we were able to put together legislation to create what is now our Division of Health Equity and Social Justice. Their focus is to work interdepartmentally within the city to identify equity issues, address problems. Recommendations were made to the mayor in 2023, 2024. And so the work is now embedded fully with that division, and they'll continue to work on that, I'm hoping, in perpetuity.
Great. That's a great segue. One thing I was thinking of, Commissioner Mills, in light of that and kind of all the work building up to that, to this current state, acknowledging the federal policy landscape in general, acknowledging state landscape, what it is now, what it could be in the near future. How do you think of what you just described in light of those pieces? And I think most organizations are trying to grapple with this, and knowing that when we look at the data, you control for things like economic status, et cetera, the disparities by race and many areas are very stark, and it's not purely an economic issue. It's sometimes economic, but there's clearly a race or ethnicity issue in terms of the disparities we have. So how are you all thinking about that in light of either changing or already changed policy approaches that this is all happening within?
Well, I think that many of our organizations have been made to operate in fear right now. And so the work is not changing. Poor people are not going away. Complex challenges are increasing just by virtue of many of the executive orders that have been handed down in the last 6 months. And so we're going to see more challenges. So this is not the time to be silent. It's not the time to lack courage. It's not the time to stop listening. It is framing the work in the same way. We want all people to thrive. Equity efforts have never been solely focused on singular populations. It's highlighting those disparities that are happening with certain groups. But the end goal has always been for everybody to thrive. And the reality is that there are certain people who are thriving and others are not. And so if we frame the work around, we are helping individuals who need our help, whatever the sector, I think that's the frame that folks have to operate. There are certain words, many words, that people are told that they can't use. There are research efforts being decimated and eliminated. The work has to continue. And so I believe that Cleveland has the resolve to keep doing the work that they've been doing, and they'll operate in ways. Much of these executive orders have come with dictates with no guidance. And so you cannot operate in a place of stagnancy. We have to keep moving forward. And so I think our sector in public health, we continue to move.
Yeah, wonderful. Thank you. I know we're getting closer to the end in a handful of minutes, but I would love, recognizing all of this, and we're all dealing with, there's the good, the bad, and the ugly of the current landscape, but there's also there's a lot of hope in what's happening. I think being here is one testament to hope. I think that we see in some areas, opportunities might be drying up due to policy shifts or funding shifts, but there are also other areas where opportunities are actually growing. And so given all of that, what do you remain most hopeful about for public health in Cleveland now, and what do you see as some tangible but tackleable priorities in the near future, given all those things?
Well, I think just the conversation and the actions and the commitments made. Collaboration looks very different than it did 5 years ago, than it did 10 years ago. People are more comfortable with calling each other out in the most helpful way in terms of doing the work and really articulating what is needed in order to be successful in the long run. This current political climate has put us in a place where this potentially will completely reshape what philanthropy is doing locally. We may not be able to go to foundations and say, we need X amount of dollars for this thing, because we have to see how the basic needs will shake out in our community, given what's happening with Medicaid, what's happening with the food banks, what's happening overall. We may see very new and more compelling access challenges that we'll all have to pivot to help address. And so the hopefulness is that there are still people who are courageous, that there are still people who are passionate about helping others, that there is a spirit of resilience in our community. Those are the things that keep me hopeful. If I ever had to look at individual leaders or individual organizations or work that was being accomplished, I might go home, go to bed, and not get up. But the work is so compelling.
Yeah.
And to see people move from point A to point B and thrive, my orientation is really around behavioral health and infant mortality and people who are unhoused, to see a person who's unhoused get the help that they need, get a job, become revitalized. That's a thing to behold, to see an organization that has tried to hoard all the money and the work and the clout and the power, give way and begin to work with others, contributing dollars, contributing time and talent. That's a worthwhile thing to see. And those are the things that keep me hopeful, to see new people. We've had a great transition in the city of Cleveland and Cuyahoga County over the last 5 years in terms of leadership. People who have been pillars in this community, they've retired, some have died off, some have said, I don't want to do this work anymore. There's young energy in this room. And so we have to leverage all of the knowledge and skills and wisdom that our older, including myself, professionals are out there to, young people like Angela, to young people in other organizations who they have the legs and they have the will and they have the desire and they're just as passionate as we are when we came into the field. So that's what keeps me hopeful.
Great, thank you. You see, if you sit in the front row, you get compliments. So let that be a lesson to you for the rest of the day. If you feel like you want some compliments, come on up. Yeah, thank you for that. And maybe as we kind of wrap up this session, last 5 minutes or so, a lot of what you've said has made me think about, as you talked, the importance of knowing the community from their voice and having that inform priorities, approaches, how we even evaluate what we've tried and how we iterate on that. And obviously a lot of the work that you do lead and have led has been around community health assessment and thinking about that space of how do we really know the needs of the community and how do we take that and make it actionable in terms of an improvement plan that doesn't sit on a shelf and gets dust on it, but actually informs all the stuff you're leading, right? So do you see that as maybe one avenue or opportunities there for having cohesion, let's say across health systems and public health and other community partners through that process so that we can really tee that up to inform all the other work you're leading?
Absolutely. I mean, there is a phenomenon in the community health needs assessment that happens every 3 years. And there is a data scan, a data review. There's conversation that happens with the community to say, this is what the data says. What do you think? And what should the priorities be that both health departments, a county board of health and a Cleveland Department of Health, what should we be working on with hospital systems and other organizations in the community? However, that's one layer of data collection, review, analysis, and planning. The community itself has really told us about the deficits of that process based on their actions. For example, the LGBT community said, this is not hitting on anything that we're doing, that expresses our needs. So we're going to do our own needs assessment. Do you want to participate? Neighborhood levels have said, yeah, you've talked about Cuyahoga County, but you haven't really talked about the city of Cleveland, but you haven't talked about my neighborhood. So we're going to do our own neighborhood level community assessment. And so there are many groups of individuals enhancing our access and our understanding to the needs that are out there with the work that they're doing. And we just overlay that and say, from a larger systemic scale, what can we do to make this better?
Awesome. That's wonderful. I think that speaks to a way of doing what you said around community voice and allowing that to surface, but then also integrating that or actually folding that into approaches that might have been lacking that before. So thank you, Commissioner Mills. Before I kind of wrap up here, any final thoughts or a call to action you'd like to leave us with as we close down this part of the session?
I'm glad you asked that question. Don't stop. Don't stop. I always talk about whenever I'm out in community, well, what can we do? As individuals, this is almost like talking to the choir, but your sphere of influence extends to patients, to clients, to friends, to family members. Civic engagement is important. Civic engagement is important. When we look at voter turnout for primaries and national elections, our responses have been waning over the last decade. It is so important to educate community members and sometimes to educate ourselves why our voices remain important and why our vote is important. If you don't like what's happening nationally, all politics is local. It starts there. And so civic engagement is where we need to do to see change happen.
Thank you. Thank you. Commissioner Mills, I just want to thank you for your leadership.
Bob,
and-
can I interrupt
Oh,
for
yeah,
one second?
please,
I was
please.
going to say, I do think, because this has been an awesome conversation. So my thought would be, I think we have enough time for, if you're open to it, a couple of questions from the audience, if that's okay.
I'm completely closed to
And
it.
those who are on Zoom, feel free to put something in the chat, but that was truly inspiring. So I do think if are there questions out here? Because I'll call on you if you don't have one. You know him, you call on somebody.
Let me see who.
Let's see, the younger people in life. You want to ask a question since you were picked out as young, invigorating, the new generation.
Thank you. When 45 is still young, I will claim it. Okay, thank you for that. So I appreciate that, Francis. Commissioner Mills. My question, I guess, would be, because I'm also, I've spent 20 years of my career in public health. And so understanding the lack, how do we amplify the importance of public health and advocate for additional resources for public health specifically when we know, and my previous health commissioner, Terry Allen, used to say, where the public health is the greatest story never told, and also the most underfunded government entity that we have. And, I know that prevention is the place that we need to focus at. And so how can we that may not be a part of public health currently help to advocate for continuous and increased investment in the amazing work that you all do?
See,
You're only 45.
you're pushing my buttons. When we talk from a local perspective, certainly the underfunding of public health really limits what we can do in the community. Advocacy efforts, beginning to ask those questions around why is that? In our local community, the Cleveland Department of Public Health has probably a 1.8% share of the total general fund budget. Why is that? Efforts have been emphasized for keeping the community safe through fire, EMS, police. Community members taking that information to community members. We have some policymakers in council, they take the actual budget to the people and explain it to them. This is how dollars are being spent in our community. Other organizations that we partner with, advocacy is, we need to have an advocacy front because government is prohibited from lobbying, but they're not prohibited from talking to their partners to advocate on their behalf when they're sitting in front of policymakers to say that public health is an important part of what we're hoping to accomplish in the local community.
Excellent. I'll go to the back of the room. I have no qualms about calling on people. Do you guys actually do maternal and infant care here at this table, since you're sitting where this sign is? Because I was going to look at, wouldn't you like to ask a question?
No.
The what now? You're calling on the online person. Okay. What was that question, Eric? Oh, a question in the back? I love it.
Good morning. My name is Abby Morgan. I'm a director at an area agency on aging in the Akron region. And I really appreciate your discussion about the multi-layer approach, multi-stakeholder approach to tackling tough issues like maternal health, and how you have to approach it from different angles, which means multiple organizations working on solving, iterating around the same issue. What I see a lot of times in partnering with governments or businesses, they see that as wasteful, that it's duplicative. And do you ever have the opportunity to address some of those challenges of, we need multiple small changes to lead to big changes, and we all kind of have to work towards that? Do you ever get that pushback, and how do you address it?
Sure, duplication. One of the great things about some of the public-private partnerships that exist in Cuyahoga County is that they're actively working to assess where duplication is happening, but also where the gaps are. And so any public-private partnership that is going to work has to be unafraid of self-assessment and, the opportunity to pick apart what's being offered in terms of continuum of care, what's not being offered, what is a hard challenge in terms of funding. Yeah, there's always going to be a pushback. Well, so-and-so is doing that. We don't need to, but that thing that so-and-so is doing may need to be enhanced. And that never happens if we don't have the capacity to assess ourselves. And that's the same strategy that works in terms of equity. Why are we doing what we're doing? Who is it going to benefit? Who is it harming? What are the gaps? What are we doing well? And what we need to make bigger investments in, and what do we need to eliminate? So those questions around duplication will always come up, but the justification is it working, and is it enhancing where we want to go as a whole?
So I'm going to take the moderator prerogative to ask both of you a question, which is one of the things that I've seen over the years, and I have to share, I've got a lot of friends at CDC who are terrified to attend meetings or return telephone calls. And there seems to be this erosion of public trust, particularly in public health. And so my question to both of you is, what can we do to better to get the public to understand and appreciate the awesome work you do?
You want to go first?
I'm happy to go first. Yeah. So I think maybe the generation or two before me, maybe my parents' generation, there was such a direct link between who was providing their care and their everyday lives that the idea of lacking trust in that person wasn't really a thing for them as much. And I think now we have so many steps in between an authentic relationship with a human that is providing care for us that I think that issue of trust is really easily questioned by folks because things are so scattered in terms of who they're engaging with. And so for me, it's like, how do we build a more authentic longitudinal relationship as individuals to really bolster that trust? Because I think we know that having strong data actually isn't enough anymore. Like that which is sad, but like truth is turned on its head, right? So like given that, how do you combat things around vaccines or systemic racism or other things if we know the data itself, which is very stark, doesn't seem to be enough? And so I think it's a relational thing in my mind, and that human-to-human interaction is key, but also even through digital pathways, how are we actually engaging with people in a humanistic way that shows care and garners trust? So for me, I think that's a key point. I don't know that's a solution so much, but that's kind of my sense of why there's an erosion of things like trust, despite overwhelming data in favor of what we see are healthy approaches to improving community and population health.
And I agree, relationship predicates everything, and the reality that bad things have happened to people. For public health, being present is you can't plan and engage community if you've never been in the community with people, engaging with stakeholders, listening to their problems, participating in solutions. And so public health cannot be lofty and distant. It has to be in the thick of things. And so it has to make its way to the table. You know, a lot of times, well, why didn't this organization or this collaborative call me? Because you haven't been present, and you haven't, you know, we have to be curious enough to care and sometimes say, well, why is that not happening? You know, I was invited to participate in community health planning because people saw the work that I was doing in terms of equity in the community, and they invited me to the table in which we had not really been a part of the table. And when I got to the table, you also have to get in the room and at the table and look around and say, who's not here? Whose interests are not being represented? So we have a role to play in order to engage better and to partner better and to build trust. You got to be there.
Thank you for volunteering me. Yeah, I appreciate it. I had raised my hand a little bit about the duplication issue. And I always fight back against duplication because I think that just because you get a meal from Benjamin Rose and you get transportation from another provider in our area, that's not duplication, even though it's coming from Older Americans Act activities. So we try to push the point that just because they're two different services coming through Older Americans Act funds, they're not duplicate. So how do you push back for people who are assisting that it is duplicate because it's the same funding stream?
Well, it's about needs. People are living in a world of complex issues. You know, if I'm hungry at the end of the month and I get a meal from Benjamin Rose, but I still need the services from a pantry or a hot meal site to make sure the cycle of food is closed for me, that's not duplication, that's fulfilling the need. If I need a ride to get to the pantry, I'm an individual that experiencing complex challenges just to move through the basics of everyday living. And so that's a conversation that we are going to continue to have with people, because sometimes we forget what it takes for people to even function.
Mhm.
So one other question here. So, you guys are awesome. I love this one.
Hello, hi Ms. Mills and hi Mr. Eick. My name is Veronica Thornton of V's Consulting and Interim Director of Creative Healing Foundation. And my question is in regards to the arts. One thing is often forgotten is the arts goes beyond the social prescribing that's recently underway, and how artists and art organizations, other than the large organizations, can help in pushing the effort for health equity and addressing a lot of public health issues. How can we go about making sure the arts and not just the large organizations are at the table, because the smaller grassroots organizations are the ones closer to the community?
That's another push button question, but thank you for it. The city of Cleveland used to have an initiative called Healthy Cleveland, and it was a committee structure of volunteers that works on specific issues in the community. And we had a committee called the Healthy Neighborhoods Committee, and that committee used art as a platform to convey and raise awareness about health issues. And the big work of that committee was developing, writing, and producing a short film called Toxic, a Black Woman's Story, that just gained a whole lot of national and local foothold in terms of raising awareness about the intersection of race and birth outcomes. Arts is a way in which it makes sending the message easier. The city of Cleveland has a whole arts initiative that's working with a bunch of organizations in order to make sure that artists out there, Cuyahoga arts and culture is out there, but it is something that in order to engage, if there's an issue that you're interested in, say, for example, food justice, connect with the policymakers around food justice and say, hey, here's an idea that we have that we believe that we could help advance awareness and understanding of food injustice in the city of Cleveland or in Cuyahoga County. Arts are very important, not only for the artists, but the recipients of those of us who benefit from looking at what is being produced, hearing what is being said, and engaging in that process between community and artists to make things a better place. So
Just
I
so you
don't-
know, there's a guy called Dr. Jeremy Noble. The Art of Healing is a national campaign, and you should be submitting stuff and be the grand prize winner. So I want to take the opportunity to thank our first panel. And this is really, really why we started in Ohio. When Nima was making his opening remarks, the work that you are doing and your inspiration is just absolutely fantastic.